Okay, good time to get up. Mm. Mm. Whoa.
Professor, are you able to check me in? Um, I had to take my cat to the emergency vet. Um, so I'm currently driving, but I'm here. I don't know if you can hear me.
Good morning, everyone. Yes, Kayla, I will check you in.
Thank you.
You're welcome.
I should be home in about 20 minutes. Cause they're
Okay,
only allowing me to drop him off. So, but
no
I'm
problem.
here and I'm listening attentively.
All right, I just checked you in. Thank you.
Thank you.
Everyone else, please turn your cameras on. A few students still showing absent. Got Simon, again, Nico, and Angie. Angie might be a few minutes late. How was the weekend, guys? Good.
Not long enough.
Not long enough? Okay, yeah, I agree with that. 100%. Mine too.
Right?
Yeah, I wanted to relax real bad, and it was not just the weekend. It's been a few weeks, and I've been trying to stretch as much as I could. But once in a while, you feel like, okay, if I have a few hours just to relax, maybe watch something on the TV. So that's at this moment like something luxury for me. I haven't been able to afford that. Last night when I was like, okay, I'm not gonna do anything else for today. It was already, I think, what, 11 something. I said, oh, well, great.
Yeah. How many classes are you teaching?
um, okay, so three. One is you guys. Second, I just concluded that um, which is Fremont. And then I also do the clinical part for capstone, which is the last semester in this program. Um, and another thing is that I'm also the CCE for the pharmacology, which is a course content expert for pharmacology. So I just kind of oversee wherever the pharmacology runs. So different things, meeting different faculties and kind of supporting them wherever they need, and also some kind of national level. You just have to kind of, there are meetings all the time, just planning things, implementing things, changes, this and that. So
Yeah.
that's
So
what I
you're
teach.
you're definitely busy then.
I think so because I didn't find spare time. So that's my guess as well. Okay, I see Simon and NG absent. I did get a message from NG earlier that you're a little late, but another student. So, well, let's move on whenever they show up. Any question you guys may have before we start the lecture? Excuse me. No, no question. Okay. Don't be so quiet, guys. I'll become sleepy, slow, sleepy, drowsy, dry. I don't want to go into that mode. I want to stay awake.
So I did have a question on last week's material. For the test this Friday, how much of the anti-arrhythmic drug classes do we need to know? I know you gave us that mnemonic to memorize, but do we need to know like all those drugs that are on the 1A, 1B, 1C kind of thing?
So I'm not 100% sure like exactly what drugs are on it, but if they are on your PowerPoints highlighted stuff, then definitely I want you to focus on them.
Okay. So everything highlighted is fair game then, right?
That is extremely important. I mean,
Okay.
that's not the only thing. I'm saying that that is something we cannot afford to skip. We need to understand, memorize that really well, because that's not only important for your exams for this course. You will see questions relevant to those topics, drugs on your NCLEX.
Okay.
Okay.
Okay. Thanks.
Because I just don't want to focus or narrow down your learning just on one thing. I want you to know what you should know as a nurse.
Yeah. Okay. I just wanted to know.
Yeah.
Yeah. Okay.
Okay, no worries. Anyone else? Any other question, guys? Anything else? No? All right. So let's start first chapter of the day. One thing I want to actually, talk to you about, and I'll definitely wanted to suggest a few things here. What I notice is a lot of students wait until the last moment, like Saturday, Sunday, to complete the ATA assignment. Okay, I would recommend you do it otherwise. Do your ATA assignments early in the week. Okay, get them done. The reason that you will learn the material, even though suppose that first time you did not achieve 90%, okay? If you're gonna go over, you're gonna learn from it without any negative consequences to your grades. But if you attempt your quiz early, well, there's only one attempt. And if you don't do well, it stays like that. So you manage or do things first, which does not have negative consequence on your grades. So ETA assignments, get them done first couple of days. And then either Saturday night or Sunday afternoon, plan to take your quiz. And before you do so, now why do we wait? Now we want to prepare ourselves in the best possible way to maximize your grades on the quiz. So the extra time should be utilized by spending enough time, which I will, always recommend hour and a half to do on each chapter you cover for the week. So learn that material, and while you're learning it, develop your study guide by downloading the framework what I provide you as study guide attachment. But remember, that is not a complete study guide. That is something for you to start with. And then everything important, what I told you during lecture, or it is highlighted on your PowerPoints. And third is, if it is listed on your study guide, even though it's not highlighted in PowerPoint. So now these 3 points, make sure you get them together. Okay, bring that from PowerPoints, insert wherever they belong. And if it's not shown there, just create a new topic there, add it to your study guide. Once you are ready, it will only take, I would say 15-20 minutes extra while you're studying just to copy paste. Don't try to write down everything. I know For some students, it's more productive when you write down things, but the problem here, with your program and how it's designed, it's very fast paced. So material is a whole lot, but the time is a whole less. So they go both on the opposite direction. So we have to come up with a strategy where we can be most productive by using less time, what we have available. It's like you have $100 and then, wisely, how should you use it? Like then you prioritize what your needs are and where less more, and you allot that funds towards that need. And similarly, you know that certain number of hours you have, and then the activities you spend them on, it should be carefully selected. Um, so when you develop your study guide, revise it. And while you're revising, create mnemonics along with that. That will help you to remember them. And then whenever you're trying to relax, you're taking a break, just pick up a piece of paper. Try to write down the mnemonics. See if you can recall, if you remember them or not. And then try to write down what that mnemonic means. It's not about just memorizing the mnemonic. Do we know that what that mnemonic means, A, B, C, D, whatever it is, what it belongs to? That will help you to answer questions correctly. Rather than trying to memorize every single drug and everything about the drug, you need to include certain tools which will help you to do well. Pharmacology is a little different. We can't just cram it. It's just never going to stick. We have to develop those tools which will condense and help us memorize and recall. And then once you do so, start doing questions on ATI, Evolve, any other resource you like, but at least those. Pick up 20, 25 questions on each platform every single day. I know it may sound a lot that, oh my goodness, already we had so much. Now he's telling another thing, 25 questions on each one, right? I know it's a lot, but this is something we need. It's not about choice. It's about what we need to do. These are requirements to do well in the course. So I'm not gonna always tell you what is easy, but I'm always gonna tell you what is right for you and what can help you to pass this course successfully. I hope that makes sense. Sometimes certain activities may seem like, oh, you know what, this is extra. It's too much. It is on top of what we have. But I always think through all activities you have. And certain, I agree that, could be more refined, but I do not have control over those things, that I could change that. That's on national level, that's how it goes. But generally, what I assign you, there's a reason behind it. So please do things in a proper way, using the resources appropriately and creating those resources, because you may already see that, how challenging it gets every week, that material volume, it's increasing, it's getting more and more complex, and it's getting mixed with the previous information you studied. And that's going to keep happening. So we need to organize things really, really neat way so that we don't let them mix. We have to stay on top all the time. Pharmacology does not like when we do not talk on a regular basis. A relationship becomes a little tense. Okay, all right. And also, I will let you know, I'm planning an extra session this week. Excuse me. How you guys, Wednesday, actually this week, I might be out of town. I have to go visit clinical sites in Gilroy and maybe another place on Wednesday. But are you guys available Thursday evening? Your exam is on Friday, right?
Yes.
So are you guys available Thursday?
I'm available.
Okay, you don't have
I'm
school,
available
right? You guys
Thursday.
don't have school on Thursday, right? Anything in school?
We have our fundamentals on Thursday. We get released at 3:30.
Okay, yeah, I mean, I'm open to come up with a time frame where it works for majority of you. You know, maybe, I don't know, like maybe 6 o'clock or something. I can look into that so that everybody can reach home safely. You get a little break to kind of eat, drink something and change and then kind of join that. Does that sound right? Is something okay?
I feel like 6 o'clock is a reasonable time.
Yeah, I think that
Okay.
sounds good.
Okay, so then I will schedule a session for Thursday and I'll send you guys a message as well, okay?
Okay, on the announcements.
I'll send a Canvas message.
Okay.
Okay, Canvas message, and I'll share the link too. So make sure, you know, before we join, just work on your, go through PowerPoints, work on your uh, study guide, and work on some calculations. So we'll pick up areas and then we'll do some questions, we'll do calculations so that you get used to those things, okay?
Mm.
Can you
Oh,
include like those, especially the IV chip rate stuff?
Yeah,
Drop
that'll be
factor.
part of the calculations.
Thank you.
Mhm. All right, let's move on, guys. First chapter of the day. Can you still see my complete full flash screen? Yes, okay.
Yes. Yes.
All right, thank you. So we're gonna go over pituitary drugs in this chapter. What are the problems with pituitary gland, because they are the ones that release different hormones. So hormonal balance and what kind of conditions patient experience and what are the medications commonly used and relevant concerns, any interactions, contraindications, that kind of stuff, and important aspects of your nursing care plan. So first of all, pituitary hormones. So pituitary hormones are regulated by your pituitary gland. And when we talk about this neuroendocrine system, so this system consists, has multiple parts. And then here in this chapter, we're talking about pituitary. So neuroendocrine system itself is a complex network which integrates the nervous system and the endocrine system. That's why it's called neuroendocrine system. Now, what does it do? Regulate physiological processes in the body. So key role it plays in maintaining homeostasis by controlling activities such as growth, metabolism, reproduction, stress response. These are all controlled by the system. Now, the neuroendocrine system, it has neuroendocrine cells which receive signal from the nervous system and respond by releasing hormones into the bloodstream. Now, what are the parts? What are the parts of this neuroendocrine system? Um, Hypothalamus, which is located in the brain. Okay. So this one, the hypothalamus, it acts as a crucial link between the nervous system and the endocrine system. It releases hormone, which regulate pituitary gland, which affects, and various target glands throughout the body. Then the hypothalamus, it produces releasing and inhibiting hormones, which control the release of the pituitary hormones. Now, the pituitary gland, which release pituitary hormone, which we'll be covering in this chapter, this is a little tiny gland here, a pea-sized gland. It's called master gland. The reason? Because it controls other endocrine glands, such as thyroid, adrenal gland, to release hormones. So it controls others. That's why it's called master gland. It has two lobes, two parts, anterior and posterior. I'm going to talk in detail later. Then there are endocrine cells, which we just mentioned previously. Those are also called, that they actually release the chemicals. They're also called catecholamines, or if you talk about by name, they're like your adrenaline and that kind of stuff. Then there's HPA axis, which is hypothalamic pituitary adrenal axis, which regulates the body's response to stress. So it is associated with your CRH, the corticotropin releasing hormone, and then ACTH, adrenocorticotropic hormone. Then next is your HPT axis, hypothalamic pituitary thyroid axis. This is involved in regulating the metabolism. And then there's HPG axis, which regulates the reproductive function. Now let's talk about, actually, I'm going to show you a quick video. Let's watch this first. Not sure if I shared the volume or not. Let me know if you can hear.
Now for endocrine glands and functions, starting with the pituitary, which I call
We
the
can hear it.
testes of the brain.
Thank you.
Since they look like a set of testicles with two lobes, the anterior and posterior pituitary. And very similarly, these two release hormones that helps the body do many functions. So starting with the anterior pituitary, this is the largest part of the pituitary gland and is responsible for synthesis and release of most pituitary hormones. So let's look at the hormone list here. Starting with ACTH, the adrenocorticotropic hormone. The effect on target is that it stimulates the adrenal cortex to release aldosterone and cortisol. And the stimulus for release is stress. The next one is FSH, the follicle stimulating hormone. In men, sperm production is the effect on the target, and for women, ovarian follicles for the release of eggs. And the stimulus for release is the GnRH, the gonadotropic releasing hormone. Next is LH, the luteinizing hormone. For men, its function is in testicular, and for women, this is the most important part. It plays a key role in ovulation, the release of the egg. And the stimulus is GnRH once again. Next is GH, growth hormone. This increases during anabolic metabolism, as well as cartilage growth and catabolism of fat, as well as blood glucose and insulin effects. And its stimulus is normal growth and development. Next is PRL, the prolactin. It stimulates the production of milk in the breast, and the stimulus for release is estrogen, pregnancy, and nursing. Next is TSH, the thyroid stimulating hormone. It stimulates thyroids to release T3 and T4 for thyroid needs. Okay, now moving on to posterior pituitary. The posterior pituitary does not necessarily produce hormones directly, but rather stores and secrete hormones produced by the hypothalamus, which is what it's connected to. Now for the hormones, ADH, the antidiuretic hormone. So for the memory trick, we use ADH, adds the H2O, because the effect on the target is it adds water back into the body by telling the kidneys to reabsorb water. And its stimulus for release is for decreasing blood pressure, pain, and even high osmolality inside the blood. Basically, really thick blood. So we need to add more water back to the body to dilute that thick blood. Now, lastly, we have oxytocin. Wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And all.
Okay. You got just a basic understanding. Now this slide is very important, okay? Extremely important. So please make sure you know everything from this slide. Now, let me tell you a little trick to make it real easy to remember. Okay. Do you see left and right side, anterior and posterior pituitary, right? That's a pituitary gland divided into two sections, anterior and posterior. Now, how do you memorize which hormone belongs to what? Remember one side, you know the other one. And which one should we remember? Which is easy to remember. Look at the right one. There's only two. Antidiuretic hormone and oxytocin. That's it. Those are the ones belongs to posterior. Any other hormone, they belong to anterior. Isn't that easy? Right?
Yeah.
All right. So just remember AO, antidiuretic, A, antidiuretic, O, oxytocin. AO belongs to posterior and everything anterior. This is important, okay? Very important to know which one belongs to what. Okay. So now we're clear. Vasopressin, oxytocin on posterior, everything else anterior. Now, what are their functions as in the video as well explained? Well, let's go over real quick. For example, growth hormone, as the name says, growth hormone which is responsible for growth. It stimulates the growth, cell production, regeneration. Who would we give it to whose growth is not normal? It has a retarded slow growth, correct? So it affects bone, muscle growth. Now, if we talk about adrenocorticotropic, it stimulates, as the name says, adrenocortical. So it stimulates the adrenal cortex. And what is the result? It produce and release corticosteroids. Example would be cortisol. And what does it do? Well, manage stress, maintain blood pressure, regulate metabolism. TSH, it's thyroid stimulating hormone. As the name says, thyroid stimulating hormone. This is a hormone which stimulates thyroid gland. And what does it do? Well, when it stimulates the thyroid gland, it's telling thyroid gland to produce more thyroid hormones. What are those? T4 and T3. So anytime, where that's very important, note it down. The lab, the gold standard lab for patients with thyroid disorder is the TSH. TSH. And what are you expecting in that lab? If person has hypothyroidism, means they have less thyroid hormones, correct? What are those? T3 and T4. T3 and T4. So whenever they are less, TSH will go opposite. It'll be high. High TSH means the messenger. It acts as a messenger telling the gland to release more, make more T3, T4 because the patient has hypothyroidism. They don't have enough. On the other hand, if the patient has hyperthyroidism, okay, means they have too much of T3, T4, then in labs, TSH will be low. Is everybody clear? Crystal clear? about the labs. In hypo and hyperthyroidism, which one goes on what end? In hypothyroidism, TSH is high, T3, T4 low. In hyperthyroidism, T3, T4 is high and TSH is low. Any questions so far? Everybody's okay? All right. So as far as your FSH and luteinizing hormone, these are your responsible, for example, in female, your triggers ovulation and stimulates the production of estrogen and progesterone, and in males stimulates the production of testosterone. That's the luteinizing hormone. And FSH, it stimulates the growth of ovarian follicles, and in males, responsible for spermatogenesis with the production of sperm. Then prolactin promotes the lactation, milk production after childbirth. And melanocyte stimulating hormone. It is responsible for melanocytes, release of melanin by melanocytes. What does it do? Influence the skin pigmentation. On the other hand, your ADH and oxytocin. So antidiuretic hormone, or also called vasopressin, it regulates water balance. How? By increasing the reabsorption in the kidneys and reducing the urine output. And oxytocin, it stimulates the uterine contractions during childbirth. Kayla, what was that?
Oh no, I was answering your question. Sorry, Professor.
So oxytocin stimulates uterine contractions during childbirth, as well as facilitates milk ejection during breastfeeding. This is also responsible in social bonding and behaviors. Okay. Now we know two lobes produce different type of hormones. And now two things can happen. Patients may have less or more of those hormones. Those are only two types of conditions you might be managing. So if it's less, you might be giving something to boost it. And if it's too much, we might need something to suppress that production. Excuse me. Now let's talk about the pituitary drugs. These are the medications. You can still see the screen, right? See, sometime, technology, you could kind of click left or right.
We can see it.
Thank you. So these drugs used to either, as I said, to produce same type of effect or suppress when it's too much. Now, if the patient is deficient, then it's hypopituitarism, and if they have too much, then hyper. Okay. Here are some drugs, such as your cosintropin, somatropin, octreotide, which is centrostatin, and the posterior pituitary drugs. Those are your vasopressin and desmopressin. Okay, let's talk about those cosintropin, somatropin. Before we start, there's an important question to know. What is the condition called if we are giving this to a patient, what condition does it come under? Like an umbrella term.
What was the question, Professor?
I said that these drugs given to patients with what condition? Remember I just mentioned two things. When they're not making enough or they're making too much, correct? So if these drugs we are giving where they are not making much, that means insufficiency, right? Insufficiency of what? Whatever the gland it belongs to, and it is connected to what? Adrenal gland. So it is called adrenal insufficiency. Okay, so know that. That's important. Adrenal insufficiency. Now, concentropin. Concentropin, it's a synthetic ACTH, which is adrenocorticotropic hormone, used primarily in diagnostic testing to assess adrenal gland functioning. It's like a stimulation test. They stimulate the adrenal cortex to produce cortisol. The adverse effect associated with these drugs are very common: sodium and water retention. And whenever you're retaining sodium and water, blood pressure is going to go high. Hydrocortisone, it's a corticosteroid. Why we use it? Patient not making it. What condition? Adrenal insufficiency. Do we know an example? Yes. Addison disease. They're not making enough. Addison. And corticosteroids are very commonly used to reduce inflammation. And somatropin and somatram, so they're recombinant form of human growth hormone. Why? Who to give? Well, it says it's a growth hormone. We're going to give it to who need it, who are deficient. So patients who are deficient in growth hormones, those are the patients we'll be giving this drug to. Okay. Now, suppose you're giving this medication to stimulate the growth. Okay, stimulate the growth. What would you monitor in the patient? What would you monitor?
Blood pressure?
Let me ask why.
Because it releases cortisol, which can result in an increase in blood pressure.
No, I'm talking about somatropin.
Oh, so much.
That's a growth hormone. What would you monitor in patient?
Height and weight.
Growth. It's a growth hormone. Patient who are deficient, that's why we are giving it. Is it working or not? How would we know if the patient is growing? So we tell the patient to keep a journal, daily log, and bring it on each appointment, every visit, so that you can assess how effective the drug is. Right? Think simple first. Growth hormone, what to monitor? Growth. Right? Don't think too complex. So that's an important thing, even though it's basic, but it's very important. Okay. Octreotide, sandostatin. So this drug It's used in a patient who has carcinoid tumors. Okay. It can cause carcinoid crisis. It's kind of, causes severe diarrhea. So this is used to inhibit that because it blocks the release of hormones. If somebody asks you how does it work, well, the mechanism of action, once again, as I said, that it inhibits the release of growth hormone. Okay. What conditions used? One I just shared with you in carcinoid tumors. There's acromegaly when they have too much of the growth hormone. So it reduces the growth hormone level in patient. This is completely opposite to the previous one. Okay, and as I said, for carcinoid crisis, where patient has a tumor which is causing release of hormones, so to block that, as well as for gastroesophageal varices, the bleeding associated with gastroesophageal varices. So it reduces the blood flow and prevent the bleeding in those patients. Okay. Just continuing with the octreotide, what else is important? We know that it's used for esophageal varices, but very important, especially the patients who are diabetic. It's more crucial to monitor those patients. It's about glucose monitoring. The reason, out of the two different type of diabetes, type 1 and type 2 is more common. And in type 2 patients, it can cause hyperglycemia. It can increase the blood glucose level. So if patient is taking octreotide, you may need to adjust their diabetic drug dosage. Suppose they're taking insulin, you know that it is going to increase, you may need to adjust the dosage. Okay, and it can cause QT prolongation. But another thing I forgot to tell, that as we talk about type 2, it can cause hyperglycemia. But if the patient has type 1, then there's a more chance of hypoglycemia. Any questions so far, guys? Many? No? Okay.
No question, Professor.
All right. If you say so, let's move on. What do you think about it? And type your answer in the chat. Good job. Yeah, looks like everybody is going with B, which is correct. So in type 2 can increase the blood glucose, and in type 1 can decrease. So we'll be monitoring blood glucose, blood sugar level. Okay. All right. Now let's talk about posterior pituitary gland and the drugs associated. First of all, what do they do, or how do they work? That's important to know. These drugs increase the reabsorption of water, where in the distal tubule as well as in the collecting duct of the nephrons and the kidneys. They concentrate urine, reducing the excretion of water, so the result should be decreased urine output. So these are the hormones which balance the water, okay? And how much should go out, how much should stay in the body. When somebody is deficient in these hormones, which is antidiuretic hormone. So think about the name again. Antidiuretic hormone. These are against, anti, opposite to the diuretic hormone. Diuretic hormone causes diuresis, means more urine go out. Antidiuretic keep a balance by not allowing too much going out. When they don't have a hormone enough which keeps the balance, the urine will keep going out. And when you give the drug, it should keep a balance by reducing the output. So the therapeutic effect of this drug would be a decreased urine output. Does that make sense? Okay. Anybody knows what condition might be used in? Anybody hear about diabetes insipidus? Not mellitus. Diabetes mellitus associated with blood glucose. Diabetes insipidus, that is associated with antidiuretic hormone.
Is that when where excessive thirst and frequent urination?
Yep. Okay. Now, what else is important from this slide? This is a very important slide, guys. Okay, so now everything highlighted here. Vasopressin, as I just said, it will reduce the urine output. So your patient should have less urine output, and that should result in less dehydration, thirst, and all those symptoms caused by the condition we're talking about. And then vasopressin is a highly potent vasoconstrictor. What happens to the blood pressure if a drug is a vasoconstrictor?
It increases.
Vasoconstriction will pace up, okay, and will increase the blood pressure. And what type of patient or what condition we wanted to increase the blood pressure? Well, somebody is in a shock or cardiac arrest, pulseless cardiac arrest, or vasodilatory shock. And you can give the vasoconstrictor to pace up the heart. So that is very important, okay? And desmopressin is also used for your hemophilia patient and for nighttime bedwetting in kids called nocturnal enuresis as a spray, nasal spray. That's what usually utilized for that purpose. Okay. Nursing implications. Well, nursing implications are always associated with, closely related with what the problem is. Such as if your patient is taking growth hormone, the most important part is to looking at the growth journal. Growth journal, and you tell the patient to keep a journal, and then bring it to every visit. Okay, so whatever the condition you are giving it for, your nursing implications could be different based on that. Now, as far as monitoring therapeutic efficacy, then always go back and ask, like, okay, what was the problem? And then compare with the current situation and see if there is any difference or not. For example, if you give vasopressin, okay, if you give vasopressin, then it should decrease the urine output. And in case you're giving for cardiogenic shock, because it's a vasoconstrictor, well, the BP should go up, it should start beating. And then if you are taking glucocorticoids, steroids, then also monitor blood pressure, because when they're taking steroids, blood pressure as well as blood glucose, it goes high. Another important point, anytime your patient is taking steroids, there are a few things that are at risk. One, I told you that the blood glucose and blood pressure will go up. Other thing, their immunity will be suppressed. So they'll be at a high risk of infections. And also important, the patient is taking steroids, and if they're experiencing any sort of pain, or they are on pain management, pain medication, make sure you don't give them NSAIDs. Reason, GI bleed, increased risk of GI bleed. Well, the next question is, what can they take? What can a super nurse give safely? Nothing. Safest approach? None.
Contact the provider and ask for an order. You're asking what?
Okay,
what
let
they
me
could
modify the
use.
question. I'm not saying what to do. I'm saying what can you give? Just say like, okay, if you have to get an order from the doctor, what would you get? What do you expect?
For the pain,
Tylenol.
Tylenol.
There you go, simple. Tylenol. Okay. And for your somatropin, monitor growth. For desmopressin, see if the patient has less symptoms of dehydration. Okay. See some questions, and then we'll take a break. Hey, nice. Yes, good job, guys. It's A, vasopressin. The reason, it's a vasoconstrictor. So when you pace up, it increase the cardiac output, more blood supply to the vital organs. Okay. All right, we're done with that chapter. Any question from this chapter? No?
Can you re-go over the relationship between when TSH goes up, then you said T3, T4 go down?
Yeah, sure, why not? All right. Excuse me. First, write down three things. Write down TSH alone. Okay. Just say on the top, write TSH, and on the other end, write down two things together, T3 and T4. T3, T4 always goes in the same direction. Okay, and TSH goes always opposite to T3 and T4. So now the patient may have two scenarios, right? Two type of conditions: when they don't have enough, which is hypo, and when they have too much, which is hyper. Now let's pick up an example. Hypothyroidism, right? We picked up hypothyroidism when patient does not have enough thyroid hormones. So remember, what are higher thyroid hormones? Write down T3, T4. That's when we talk about thyroid hormones, we're talking about T3, T4. And whenever we talk about somebody hypothyroidism, what is less? T3, T4. And whenever T3, T4 are low, put an arrow upwards, write down TSH. So if T3, T4 are down, as in the case of hypothyroidism, TSH will be higher. So you look at hypothyroidism labs, TSH will be high, T3, T4 will be low. Now, let's go to the other side. Hyperthyroidism. Patients with hyperthyroidism means hyper, too much of thyroid hormones. Now, what are the thyroid hormones? T3, T4. So now it's clear. Hyperthyroidism patients have too much T3, T4. So put an arrow upwards, write down T3, T4. Now, as we know, TSH don't like to walk together in the same direction. So now it says, hey, I'm heading downwards. So put an arrow downwards, that belongs to TSH. So in hyperthyroidism, thyroid hormones are more, which is T3, T4, and TSH is low.
Okay, perfect. Thank you so much for clarifying that.
No worries. Anybody who still did not get it, I can go over again. Is it clear to everyone?
Yeah, I seem good on it at least.
Okay. Anyone else, guys? Because this is important. If you don't know these things, you won't understand the concept. Everybody okay?
Yeah.
Yes. All right. Okay, you guys ready for a break?
Yes.
So, okay, all right. Do you want to take a 15?
Sure, that sounds good.
All right, perfect. Let's take 15 minutes.
Okay.
Thank you.
Thank you.
Okay, welcome back, everyone. Turn the camera back on. All right, so second chapter of the day. This is the thyroid and anti-thyroid drugs. We talked about the gland, the problem, and now we'll focus on few conditions which are common and important. So we'll talk about the thyroid gland and these hormones imbalance, less or more, means the conditions, hypo or hyperthyroidism, and then the medications used to either lift up when they're deficient or suppress when they're producing too much. Then contraindication, any interactions, and as well as important aspects when you're developing a nursing care plan for a patient who might be on one of these drugs. So first of all, let's know a little bit more about the thyroid gland. So thyroid gland is right here. Okay, right here. So butterfly shape. It's an endocrine gland in front of the trachea. Now, what is the role? Crucial role. It has a crucial role in regulating the metabolism. That's why when patients suffering from hypothyroidism, the metabolism goes slow. The metabolism goes slow even though they don't eat much, but they still gain weight. Metabolism is low, they feel cold. Metabolism is low or slow, the patient is low and slow. Depressive symptoms. There are many things which are associated with that. And in hyperthyroidism, they'll be completely opposite. So it's important to know what's wrong and what are the signs and symptoms so that you can identify the condition. Now, first of all, the important lab. Which lab do you monitor?
The TSH.
T3, T4.
TSH. Okay. In practice, regular basis, you will see TSH, T3, T4, everything in there. Mine collects TSH. Okay, now, which one goes up and what is down in hypothyroidism?
Hypo or
The
hyper?
TSH.
In hypo,
TSH is low, T3, T4 is high.
The opposite.
For hypo?
Yeah.
hypo, okay,
The
remember,
TSH is
hypo means less. Less
Oh.
what? Thyroid hormones. Thyroid hormones are what? T3, T4. So T3, T4 are less in hypothyroidism, and TSH goes opposite.
Sorry, I thought you said hyper, not hypo.
Okay. So in hyper, T3, T4 is high and TSH is low. Okay. So once again, what role does they play? Metabolism. That's one of the biggest things. Growth, development. Okay. I want to show you a little video. That's a short one.
Nestled in the tissues of your neck is a small, unassuming organ that wields enormous power over your body. It's called the thyroid. Like the operations manager in a company, its role is to make sure that the cells in your body are working properly. It does that by using hormones to deliver messages to every single one of them. This high-ranking organ is made up of lobules that each contain smaller cells called follicles, which store the hormones the thyroid sends out into your blood. Two of the most important hormones it produces are thyroxine and triiodothyronine, or T3 and T4. As messengers, the hormone's job is to instruct every cell in the body when to consume oxygen and nutrients. That maintains the body's metabolism, the series of reactions our cells perform to provide us with energy. This hormonal notification from the thyroid gets the heart pumping more efficiently and makes our cells break down nutrients faster. When you need more energy, the thyroid helps by sending out hormones to increase metabolism. Ultimately, the thyroid allows our cells to use energy, grow, and reproduce. The thyroid is controlled by the pituitary gland, a hormonal gland deep in the brain that oversees the thyroid's tasks, making sure it knows when to send out its messengers. The pituitary's role is to sense if hormone levels in the blood are too low or too high, in which case it sends out instructions in the form of the thyroid-stimulating hormone. Even in this tightly controlled system, however, management sometimes slips up. Certain diseases, growths in the thyroid, or chemical imbalances in the body can confuse the organ and make it deaf to the pituitary's guiding commands. The first problem this causes is hyperthyroidism, which happens when the organ sends out too many hormones. That means the cells are overloaded with instructions to consume nutrients and oxygen. They become overactive as a result, meaning a person with hyperthyroidism experiences a higher metabolism, signaled by a faster heartbeat, constant hunger, and rapid weight loss. They also feel hot, sweaty, anxious, and find it difficult to sleep. The opposite problem is hypothyroidism, which happens when the thyroid sends out too few hormones, meaning the body's cells don't have as many messengers to guide them. In response, cells grow listless and metabolism slows. People with hypothyroidism see symptoms in weight gain, sluggishness, sensitivity to cold, swollen joints, and feeling low. Luckily, there are medical treatments that can help trigger the thyroid's activities again and bring the body back to a steady metabolic rate. For such a little organ, the thyroid wields an awful lot of power, but a healthy thyroid manages our cells so effectively that it can keep us running smoothly without us even noticing it's there.
Okay, hope the video gave just a little bit visual idea. Let's look into another video.
Now for endocrine glands and functions, starting with the pituitary, which I call the testes of the brain, since they look like a set of testicles with two lobes, the anterior and posterior pituitary. And very similarly, they too release hormones that help the body do many functions. So starting with the anterior pituitary, this is the largest part of the pituitary gland and is responsible for synthesis and release of most pituitary hormones. So let's look at the hormone list here. Starting with ACTH, the adrenocorticotropic hormone. The effect on target.
Actually, I'm going to skip this because it's lengthy at the end. Let me explain these things. We watched major part earlier, so let's skip this. Let's go over the detail here. Okay, now let's pick up the first condition when body is not making enough. means the thyroid gland is not making enough thyroid hormone. Which one are those? T3, T4, right? T3, T4 are not enough. So first is to know the name of the condition. It's called hypothyroidism or underactive thyroid, where the gland doesn't produce enough of hormones, thyroid hormone, T3, T4. And which one goes high?
TSH.
TSH, okay. There's a condition, it's called Hashimoto's disease or thyroiditis. That falls under this class where the immune system attacks the own thyroid, damages it, and then they're not making enough after that. Okay, that is an autoimmune condition. Then there's a iodine deficiency can cause that, or somebody has hyperthyroidism and then they had a thyroidectomy that they cut off a part or complete thyroid gland and now they cannot make it. So, or somebody had a radiation therapy. Certain medications can cause that, such as lithium, or a baby born with that called congenital hypothyroidism. Somebody asks you, baby's born with hypothyroidism, what it's called? Congenital hypothyroidism. Okay. Now, important to know is what are the signs and symptoms? How would you know patient experiencing hypo or hyperthyroidism? The labs will confirm, but without the labs, how do you know? And you don't check labs every day, but the patient, if they started on levothyroxine, how would you know, like, if the symptoms are improving or not? Are the symptoms associated with hypo or hyperthyroidism? Okay. Now, as I said, this gland or the hormones associated with metabolism, and in hypo, it's low. The metabolism is low. So think about it. Somebody low, slow, what happens to them? Somebody low and slow, don't want to go anywhere, just sit alone, kind of depressive, okay? Right? Completely opposite. If somebody has too much in the condition hyperthyroidism, they will be anxious rather than depressive. Now going back to hypothyroidism, low and slow. Do they want to go for walks, work out, eat healthy, all that? No, right? So when they don't eat healthy, they don't walk, what happens? They gain weight, right? They get constipated. Now, on the other hand, when patient has too much anxious, they're walking, they're doing things, and now they lose weight. Their metabolism is fast, consume more energy, right? They lose weight. Now, when somebody in hypo, low and slow, are they more sleepy or they more awake?
Sleepy.
More sleepy, right? But in hyperthyroidism, they will have hard time sleeping. They
Won't
experience
they
insomnia.
also, will they be tachycardic also? Like have
Correct.
tachycardia? Okay.
Correct. So in hypo, it's low. Heart rate is low. In hyper, it's high. Okay. Just keep it simple. In hypo, things goes low. In hyper, things goes high. Whether it's the activity, conscious level, or heart rate, it goes high and hypo goes low. Okay, now somebody low and slow, don't want to move anywhere. Just to put it on anybody, like just apply it on yourself. Okay, that if you're low, slow, don't want to move around, do things. What do you feel at that time? Don't you guys like, we all feel like, okay, let me just pull the something on myself, right? Do you feel cold? Blanket, right? Cozy, just kind of get in there. metabolism is low, energy is low, their body is low means cold. They feel cold. On the other side, hyperthyroidism, they feel hot. Okay? And menstrual irregularities can happen both sides, hypo and hyper. Also, the hairs are usually in hypo, they're dry, and the nails are brittle. Is everybody clear, familiar with signs and symptoms associated with hypothyroidism? Anybody doubtful what they are and why they are? All clear? All right. So now we know the problem, where it is, why it is, what are the signs and symptoms. We identified it, we know the lab, established patient has hypothyroidism. Now we know patient has a problem, the thyroid gland, it's not gonna make its own. Then what can we do? We give them thyroid replacement therapy. What is the drug of choice?
Levothyroxine.
Levothyroxine. That is the drug of choice. And do we know why? WHY and a big question mark.
It replaces the thyroid hormone.
Yeah, but then there are other drugs. Why levothyroxine is the first choice?
It has a long half-life.
Okay, anything else?
It can be prescribed for both children and for adults.
Not as many side effects.
Okay. All right, let's talk about levothyroxine now. So the drug of choice number 1 is levothyroxine. For which condition? Hypo or hypothyroidism?
Hypo.
Hypo. Everybody clear? We're talking about hypothyroidism. So levothyroxine is the drug of choice, right? Now, what's in the levothyroxine? We call it what? Replacement, right? Thyroid replacement drug. What is deficient?
Iodine.
That's a big one, Jennifer. Okay, in hypothyroidism, what are the patients deficient in? Thyroid hormones, which one?
T3, T4.
Isn't T3, T4? Correct?
Yes.
Not iodine. Okay, T3, T4, we're talking about thyroid hormones they're deficient in. So we came up with 2, T3, T4. Which one is this? This is T4. Well, then where did the T3 go? Well, this T4 gets converted into T3 in the body. That's what the active form is. Okay. Well, now next question. Why don't we just give them T3, right? Isn't that a fair question, Gen 1? Oh, we're playing around here like giving T4. Hey, body, can you convert T3? And body says, just give me T3, right? Why we don't give it? Any issues? Any concerns?
Because you want the thyroid to stay active, right? So you still want it to do a job, like by converting it.
But the job it's gonna play when you have the T3 active. But what if you give them T3?
T4 has a longer tough life.
Are you sure, Killa?
Yes.
Yeah. Okay, that's
I
okay.
remember reading that correctly. T4 has a lasts longer than T3.
Okay, if you give them T3, first of all, the T3 does not have good absorption giving straight. You may need a much higher dose to produce same kind of effect. And it's not consistently absorbed. The amount and consistency is not there. That's why you give them T4, which eventually gets absorbed well, consistently, and gets converted into adequate amount of T3.
Oh.
Okay. Is everybody clear? Yes. Okay. Now we figured that out. The why T4. But there are patients, okay, they say like, okay, you know, I want something more natural. Okay, I don't want like, but there are products, but they are more expensive. There's a there's a live which is your your live tricks, which is the T3, but once again, not consistent. Then there's another product, which is a combination. This live, actually, I messed up. Here, live thyronine is T3. Live tricks is the combination of T4 and T3. Combination of both T4, T3. Well, usually insurances don't want to pay for it. They want to go with levothyroxine, and they said it's not justified paying that much when levothyroxine is good enough. Okay. Do. Okay, let me show you another thing. You may not need to memorize or calculate based on that, but I want you to know it. It's good to know, okay? Because in whatever the clinical settings you work in, you're going to see a lot of patients with hypothyroidism. It's good to know these basic things. Have you ever noticed levothyroxine? Has anybody seen ever levothyroxine tablet? Anybody? Buddy? Oh, wow, that's surprising. Okay. Well, anyways, levothyroxine comes in different colors based on their dosage, their strength. And there's a reason behind that. I'll share that with you. Excuse me. Now, the dosage is calculated based on the patient's weight. Normal, healthy adult. The dosage is calculated as, like, you know, you pick up the weight in kilogram, multiply with 1.6 microgram per kilogram per day. So it's once a day. Okay. Say patient weighs 50 kilogram. So if you have to calculate the dose, 50 kilogram multiplied with 1.6 microgram, that will give you the daily dose for that patient. Understood? If the patient is old, you usually just give with a single, you know, you might start with like 25 microgram, even though the weight is more. But in old patient, there's a saying that start low, go slow. Okay. Start low, go slow. Always start with a low dose. And then when you're increasing it also slowly, because their body, it acts differently, respond differently to drugs as compared to normal healthy adults. So for normal healthy, 1.6 microgram per kg per day. That's how it's calculated. Let me tell you another thing, and you're going to see that as well. What do you think usually for any condition just got diagnosed and the patient is pregnant? What would you think first?
That it's related to the pregnancy that they became hypothyroid, like low on thyroid.
Okay, then whatever it is, the patient has been given a prescription for levothyroxine. What is the next concern or question?
If it's harmful to the baby.
Yeah, safety, right? Can you give it safely? Because pregnancy is high risk, not only to mom, to the baby. Correct? And usually drugs, you have to be very careful. You have to look, pregnancy categories in there. One thing different, and that's why I'm kind of pointing out here, levothyroxine is pregnancy category A. What that means is there are no reported cases ever, any adverse effect to the mom or the fetus during pregnancy. Clear? So if you see a question with pregnant patient, levothyroxine, just think that they're trying to play with your mind, that you're going to freak out. Oh, patient is pregnant. Let me be safe. This is completely safe. Never, ever anything negative reported. But there's additional thing you also need to know. Stepping back, how do you calculate the daily dose for levothyroxine?
Kilograms by multiplied by 1.6.
Yeah, and what is kilogram? It's weight, right? It represents weight, correct? Now, can you correlate in pregnant patients that specific criteria, the weight? Does the weight increase or decrease?
Increase.
Increase. So then what would happen to the dosage?
It would have to increase as the pregnancy progressed.
Yeah, so you have to increase the dose, and as they deliver the baby, you need to taper it down.
Okay.
Everybody good? That
Don't they
concept.
adjust the dose based on labs that come back though? So like
You-
they can.
You always do that. You continuously monitor the labs, but the basic rule, you got to start, right, with the established data, that how does it go, how patients respond. So based on that, you go, but every patient, every human body is unique. It's different. You will see patients need more than usual. You will see patient needs less than usual. And that is driven from the labs. So you adjust dosage, but this is how you start. Make sense?
And people like it when they have like a little bit extra because gives them like extra energy.
No, people say that. That should not be the case, because then they will go through severe adverse effect, anxiety, palpitations, heart is beating too fast. Then they might start losing weight, and the people say, oh, I want to lose weight. Well, not that way. There's much more adverse effects associated. You cannot use it for that purpose. Okay. I'm gonna actually connect that. Remember, I started with that it comes in different colors, right? And the reason is that a slight dosage change can make a huge difference in patient symptoms. If it's less, even a little bit, patient will still experience many symptoms. But if it gets increased than what they need, they will experience the other end as well. So that's why there are so many different dosages available, and they color coded so the patient don't get confused. And also, if a healthcare provider, nurse, anybody else giving them any pills, they could also identify. It's like another filter so that they don't take a wrong dosage. Okay, and see how they look like. See, 25 microgram. Now somebody needs 12.5. What you do is you cut it half, right? Now 25 you will give the whole pill. But the next is 50. What if you need to go in between? Then 25 and then cut another half. That'll make what? 37.5, right? And jumping from there, full 50. And as you move forward slowly, the dosage jump will be more tight, smaller. See, here it was 25, right? Here it's only 13. Here it's only 12, 13, 12. So the reason as they go up, usually after, like even actually 75 is a very common one. 50, 75 is very common. That's where majority of the patients will be aligned with. Now, moving up, there's more closer dosages so that people don't experience the other side, the hypothyroidism, while they're being treated for hypothyroidism. There's a chance slight dose increase will put them at risk of toxicity or signs and symptoms similar to hyperthyroidism. So they have more closer dosages there and a slow increase if needed up there. That's why there's so many dosages. You don't have to remember it, but just for your knowledge, you can create a mnemonic. Like I realize, as shown on the top, orangutans will vomit on you right before they become large, proud gorillas. That will give you the color for all these strengths, 25 O for orange, white, violet, olive. Then you can, if you know this mnemonic, you can tell what strength the levothyroxine pill is. Okay. All right. Now, adverse effect. Remember, adverse effects are completely opposite to what you're trying to fix. Now, the patient was what? Slow, sleepy, right? Slow, sleepy, drowsy, all kind of stuff. Now, if they have too much, heart was slow, heart might be fast now, right? Palpitation. They were sleepy, now they may experience insomnia, correct? Anxiety. Now, in the disease with hypothyroidism, they were gaining weight. But if it's too much, adverse effect might be they're losing weight now. They were feeling cold, and now they may feel hot. So these can indicate adverse effect or potential toxicity signs and symptoms. So monitor your patient. Okay, let me bring in one more thing here. Remember, it says may also cause tachycardia, palpitation, angina, hypertension, and insomnia, correct? Patient will be anxious and may have hard time sleeping. When should you give this medication?
It should always be taken in the morning.
In the morning. That is important to know, guys, okay? This should be given in the morning. Multiple reasons. Number one, we just talked about insomnia. If you give it later, well, the patient will keep pressing the call light. Hey, nurse, what are you doing? I need your help. And nurse is busy. Say, I have other patients too. Well, the patient doesn't care. If you're not listening to them, well, you're not a good nurse, right? We call the charge nurse. Hey, this nurse is mean. Pressing the call button, not coming, right? And you're saying, oh, ma'am, ma'am or sir, could you, try to go to bed, relax, you'll feel better. And they're like, no, I'm better. I want you to sit down here and talk to me, right? So you don't want to keep them awake. Number two, you want medication absorbed consistently in the same amount every day. So when your stomach is empty and you take it empty stomach every day, well, you take it empty stomach every day, there are no factors which can alter the absorption of the drug, right? It's empty stomach. Now suppose if you say take it with breakfast, okay? Take it breakfast. Today, you decided to eat just a couple of slices of bread, toast, right? Next day, you say like, no, I'm hungry. I want to eat more. Like, okay, today I'm eating pancakes. Tomorrow, it's kind of eggs or something, whatever you decide. Now, each food is different. Okay, food is different. Now, that food, based on what they are, what they're made of, can decrease the absorption of levothyroxine. So if the absorption is decreased, well, the less drug is available to help the patient in signs and symptoms of hypothyroidism. So they will experience worse, more symptoms, correct? That's why we want to give it when there's no other people around, right? There's nobody, no food, nothing, no variation consistently, same level of absorption every day. Everybody's good? We're on the same page? Okay. Okay, now, in some scenarios, the people are taking anticoagulants, it can increase the effect of the oral anticoagulants, means there might be risk of bleeding. It's not one of the big things, but there's risk. So what are the big things here? Adverse effect monitor, that is very important, guys. Okay, monitor adverse effect. What are those? Cardiac arrhythmia, tachycardia, right? Faster, insomnia, anxiety, nervousness, feeling hot. These are important things to monitor. And what do they tell you? Patient is experiencing something. What something? Patient not experiencing anything.
Adverse effect.
Adverse effect. So that might require to lower the dose, right? Okay. Always get the baseline vital signs so that you can compare your T3, T4, TSH. That's what you monitor. And once again, during pregnancy, dose goes up. Okay. Excuse me. As we just talked about, it should be given in the morning, empty stomach, same time every day. That will help better and consistent absorption of the drug, which eventually help in controlling their symptoms better on a consistent basis. Number 2 was insomnia. We do not want to keep the patient awake if we give it later in the day. Next, do not give it with. Number 1, antacid. Make it a basic thumb rule. Do not give any drug with antacids along. What can you do? Separate them at least 1 to 2 hours. Because antacid goes anti against all drugs. They make them less effective. They decrease their absorption. They neutralize them. So always, not only this medication, any medication, never ever give them along with antacids. Next, do not give them with aluminum, calcium, magnesium. Why? They make an insoluble bond, make the drug to exit the body without producing therapeutic effect. Okay. Now, this is common. Remember, we talked about a pregnant patient. What if the pregnant patient, comes to you, they have hypothyroidism, and it's very common. Patient is anemic and or during pregnancy, right? might be an iron pills. Well, once again, separated. Now calcium. Maybe they're young, you don't need it for stronger bones. Well, what if in pregnancy, common condition, um, acid reflux, okay, and they are taking antacid, which may have calcium. They have calcium, aluminum, magnesium. So avoid those things. And also avoid iodine. Okay. Everybody is completely clear about these things. Any question, any concern, anything which does not make any sense to you, please let me know. No, nothing makes sense. Everybody's okay, guys? Yeah?
So they should basically take the thyroid medicine in the morning on an empty stomach without any other medication. So just take it first.
100% correct.
Okay.
Any other question, guys?
If they were in between the dosages, what did you say to do? Like if they were in between the orange and the white pill, like they needed 35, what were they required to do?
Oh, then you can cut into half one of the pill.
Okay, got it.
Like if the patient needs to take 37.5 and you have either 50 or 75, right? Then you cut 25, another 25, right? That would make 12.5. So then 25 plus 12.5, 37.5.
Okay, thank you.
Any other question, guys? Anything else bothering your mind? All right, let's do some questions. Anytime when you read a question, I always say a few things. Number one, think like an actual situation. Patient with that condition or signs and symptom as you're standing there. Think like that. Number two, find a keyword. Okay, good job. Good job. Okay. Now, the patient taking a thyroid replacement medication, just pick up an example of levothyroxine, right? The patient taking the levothyroxine tells the nurse she's starting to experience cold intolerance, depression, constipation, dry skin. That means she's still experiencing signs and symptoms of hypothyroidism, right? Slow, sleepy, cold, depressed. That's what they're telling. Means the dose is not enough. You need to increase the dose. Correct? What if the patient is now feeling hot? They're anxious. They can't sleep. Yes, Daniel, good job. Yeah, lower the dose, lower the dose. Okay. Now let's talk about completely opposite condition, hyperthyroidism. So I assume now everybody knows what we're talking about. The hypo, there's a common one, which is Hashimoto's disease or thyroiditis. Here it's called Graves' disease, Graves' disease. Okay. If you see this, it's called axothalamus or bulging eyes. That's a very kind of prominent feature when somebody's experiencing hyperthyroidism, eyes like that all the time. Okay, they're associated with hyperthyroidism. Now, what is high and what is low? Is T3, T4 high or low?
T3, T4 will be high.
Yeah, and TSH will be low,
Low.
right? So we know the labs now. So what are the signs and symptoms associated with hyperthyroidism? How the patient will feel?
They're going to feel anxious, hyper. They're going to have a fast heartbeat and feel hot.
Yeah.
And I think their hair falls out.
Diarrhea, you feel hot, all kind of stuff. They're anxious, can't sleep. So weight loss is also very common, and they're always feeling hot. They're nervous, maybe tremors. So those are important things. And this is what it says. We just talked about that, okay? It's the same signs and symptoms. Once we know what the problem is, we need a solution. Solution, there are a couple of drugs which are important for you to know. Number one, propylthiouracil. In short, it's called PTU, propylthiouracil. Second is methimazole. Okay. Now, what is important to know about these drugs? So they suppress the production of T3, T4, as well as conversion of T4 to T3. Well, important to know about these two drugs. Let's talk about first propylthiouracil, and it is associated with pregnancy because of safety. Okay, divided into two different phases: first trimester and after. First trimester and after. Which one to take during first trimester and which should be after first trimester? So during first trimester, you take PTU, propylthiouracil. After first trimester, you start methimazole. Everybody understood? Because there are certain adverse effects associated during that. There's they're called conal and esophageal atresia of fetus if they're given methimazole, in the first trimester, and maternal hepatotoxicity, liver damage, if PTU given and the other. So that's why they specified which one to give in the first trimester, which one to give after that. Okay. So in the first trimester, if you give methimazole, adverse effects associated with the fetus because they're developing organs. Okay. And if you give PTU after the first trimester, then the chance is liver damage on mother. Okay, is that clear to everyone? Any confusion? Any question?
So what are like the benefits of taking one over the other besides like the pregnancy, or why wouldn't you just use methimazole for the entire pregnancy?
So let me explain it again. Both are not appropriate to give during the whole pregnancy because in certain trimesters, they have severe adverse effects either to the mom or the baby. So now we give them propylthiouracil in the first trimester, because if you decide you're going to give methimazole whole pregnancy, okay, whole pregnancy, then during the first trimester, when the fetus is forming those vital organs, all right, and especially there's certain conditions that develop. It's called conal and esophageal atresia. There's severe conditions associated with the fetus. Okay, if you give methimazole in the first trimester, that's why to keep it safe, we give them PTU. But if you continue the PTU for longer, right? If you don't discontinue after the first trimester, it can damage mother's liver. So we gotta discontinue it. Okay. All right. So these are very important things. Okay. They ask questions on this all the time. All right. We just talked about this. We covered it. So it's nothing new. Contraindications. Okay. Contraindications. Who might be at a high risk if you give these medication? We talked about the top part already. But these drugs, okay, these drugs can cause bone marrow suppression. Bone marrow suppression. So if patient is going through chemotherapy, have leukopenia, WBC down, well, this drug is going to suppress bone marrow. Bone marrow produces blood cells. They'll be at a much higher risk. Liver toxicity. Remember, that's one of the things that we're not giving to the mom after the first trimester, because if you continue, they put them at risk of hepatotoxicity. That's a liver toxicity. All right, nursing implications. Because remember that drug we just talked about, these drugs can cause bone marrow suppression. Bone marrow produces blood cells, correct? What test do you use to monitor blood cells?
CBC.
CBC. So here we go. If the patient are taking this medication, propylthiouracil or the methimazole, you should monitor their CBC. Makes sense? Is that associated important? Because we know that can happen, right? So if we know, what can we do? Well, we can monitor and tell the patient that, especially what we're talking about, your hypothyroidism, that this is, unless they're lucky, have seen handful of cases. Maybe I'm just assuming that maybe they had some other thing going on which caused their T3, T4 to go down, and they maybe they got diagnosed as with hypothyroidism. But actually, it was not the gland, which has any issues. Or maybe something else was causing that, and they discontinued. But generally, and as for NCLEX, this is a lifelong treatment. Okay, levothyroxine, lifelong. So take it at the same time. Do not skip the dose. Do not abruptly stop. These should be important educational points. Then as somebody says, monitor therapeutic response or outcome. What is the therapeutic outcome? Well, start from the symptoms. They were low, slow. They didn't have energy. They didn't have the mood. Now, do they have energy? Are they more active? They didn't have that mood to do anything, right? But are they now more interested? Are they engaging in things, right? Energy level is improved. Can they think clearly? They can do things better. Now they have that strength to do things. Anything what they were experiencing in the beginning, if not absent, at least it's minimal now, it's decreased symptoms. Well, that tells you the patient is experiencing therapeutic efficacy of the drug, right? That it's therapeutically effective. And when you're doing so, equally important that you monitor for adverse effect. So if you're giving them levothyroxine, adverse effect will be opposite. If you're giving them anti-hyperthyroid drugs to manage hyperthyroidism, then adverse effect would be whatever the signs and symptoms they experience in hypothyroidism. Okay, let's do some questions. Excuse me. Looks like everybody wanna do. All right, D. Take the medication on an empty do stomach. All right. And we all know why, right? Yeah. All right. Tough choice. 4 choices of food. What do you like, guys? What do you want to save? You're gonna take away the 3 plates. Looks like everybody likes pasta with marinara sauce. Yeah? That's what you want to save? Yeah? All right. I also align with you. I'll eat that, guys, okay? Your choice. And that's the right one. Because we want to avoid any food which may have iodine. Soya, tofu, seafood may have traces of that. That is the reason we are going to avoid that. All right. Now, do you guys want to do a fun question? NGN. You know what that is? No games, no question.
Oh,
NGN, no games.
I have a question. So,
Yeah.
so it says the question says anti-thyroid medication, and this is also applicable for thyroid replacement medication as well, right?
Okay.
Like because on the slides it says it's for thyroid replacement drugs.
Okay. Remember, one condition when it's not making you need replacement. Other condition when they are making too much, that is hyper condition when you need something to suppress. They cannot be used for the same thing. If one is going to increase, it's going to increase. If somebody has hyperthyroidism too, the drug is going to do what it's supposed to do. It cannot differentiate if somebody has hypo or hyperthyroidism. It's going to do what it's supposed to do.
I'm talking about the interactions for the food.
Which one?
So the question right now is, which would be the best menu choice? So these are all iodine rich foods, like the ones that are not the right answers. So it would have interactions with thyroid replacement drugs as well, right?
Yes,
Okay.
yes. It will alter the absorption of levothyroxine. Okay, let's do an NGN, new generation NCLEX questions. So these are the new ones. Now, do not stress out by looking at how big the question is, okay? That's one thing. There's a lot of information. And one drawback is that it takes time to read the amount of information given. But the good thing is you have more information now to find the correct answer. I give you all the basics behind the right and wrong options. And I have seen a high NCLEX passing rates since they included these questions. Okay, so don't just listen to people saying, oh, they made it so hard. No, it's not like that. Look here now, and we start developing our thought. Patient 36-year-old female reports fatigue, exhaustion, difficulty waking from in the morning, trouble concentrating. She gained 10 pounds over 2 weeks. Now, the two conditions we studied, hypo and hyperthyroidism, which one do you think it's indicating?
Hypo.
Hypo.
Hypo, right? Low and slow. Now let's move further. Client admitted enlarged thyroid. It could be in both, okay? Puffy face, dry, pale skin, once again, indicating hypo. She is wearing a heavy sweater on a warm day. Remember, they feel cold, right? Confirmation. She states she has body aches all over, frequent muscle cramping, and constipation. Once again, hypo. Her nails are brittle. Hair is coarse and dry. Once again, hypo. She reports feeling depressed. Once again, hypo. So all these things correlate. No contraindicatory statements. Everything pointing to hypothyroidism. Right? Let's move on. Temperature, heart rate, and here, heart rate low. That's what happens in hypo, correct? Respiration fine, a little high blood pressure because the heart rate is low. Now, maybe the heart is trying to compensate. Oxygen fine, weight here. Now, let's look into the lab. Now in hypo, T3, T4 low and TSH high. So let's see if TSH is higher now. TSH 20.8 should be between 0.3 to 5. Once again, aligns with hypothyroidism, right? Let's check T3, T4, like T4, supposed to be between 5 to 12, but it is low. It tells T3, T4 low. So confirmation, we got the patient with hypothyroidism, correct? All right, now they want us to select the condition, right? What is the condition here?
Hypothyroidism.
We're clear. Now they're asking us pay actions to take. Two of the actions here. Now, give pre-operative teaching for thyroidectomy. Do you do surgery in hypo or hyperthyroidism?
In hyper.
In hyper, right? To cutting off a part so that they're making less. Cross it out, doesn't belong. Encourage increased calorie intake. Does that have anything to do with calorie intake? No. Leave it. Third, provide information on anti-thyroid therapy. Who do we give anti-thyroid?
Someone who has hyperthyroid.
Yeah, who's making too much? Anti-thyroid. That's a cross. So all we got left, the two bottom one, discuss the importance of thyroid hormone therapy, right? The replacement therapy. That belongs to hypothyroidism. And teach ways to prevent skin breakdown because they have dry skin. Everybody with me on that? Agree?
Yes.
All right. Now, parameters to monitor. Bleeding. Did we ever talked about bleeding associated with
No.
levothyroxine or other?
No.
That's none of a concern unless the patient is on blood thinners and interactions. That's something. Fluid intake and output. Does it have anything to do with fluid? It has nothing to do with the cardiac system, right?
No.
It's a hormonal problem. Lab values. Yes, always lab values. That's what is going to tell us how the patient is doing now. T3, T4, TSH, all that, right? Those are labs. Next, neurological status. Did the patient have any issues with their mind? Anything neurological? Anything going on? No.
No.
Then vital signs?
Yes.
Absolutely yes. So these are two options which you should be monitoring. Okay, everybody agree on that? All these options? Right. Okay, we are done with this chapter. You guys want to take a BBB break?
Sure.
Yes.
All right. You guys can take a 15. All right, I'll pace up after that. Enjoy your break. Okay, welcome back, everyone. Please turn on your cameras. Okay, let's move on to our last chapter of the day. All right, you guys ready for antidiabetic chapter? This is extremely important and it's a very common condition and it's getting worse and worse day by day. And I don't see slowing down. I don't see this thing slowing down. I would say next 5 to 10 years, this is going to be a big concern. It is still even now, but it's going to be even much bigger. All right, so we'll talk about diabetes, types of diabetes, different type of drugs used, and interaction, contraindication, all important aspect. And some of them are a little tricky, but you will understand them and remember them if you learn the whole chain, whole concept. Don't try to memorize the drug again. Know what the problem is and how the drug is going to fix the problem. That will give you all the answers, like what is the mechanism of action, what the adverse effects are. They're all connected. For this chapter, what I want you to do is make sure you can identify drugs. How do they work? Based on the problem. Problem here is high blood glucose. And how these drugs are going to fix it. They're now going to work in the same way. So I want you to understand like which one acts how and what are the associated risk with that, any administration which is different, what to watch for. I'll point out, make sure you arrange things in such a way that they're not in long paragraphs and they just kind of get taken over more and more and more information stacked on top of them. Make sure the important information is clear to you. Okay. Now, first of all, the question, what is diabetes? Diabetes simply means too much sugar in the blood. Okay, high blood glucose. High glucose in the blood, right? Why high glucose in the blood? Anybody? And please share what you know. Wow. Excuse me.
Because they've built up insulin resistance.
Yeah, so maybe they build insulin resistance or the sensitivity has gone down, right? So it's a chronic metabolic disorder. A patient has high blood glucose due to either insufficient insulin production, there's not enough insulin. What does insulin, like what type of role insulin plays?
Lowers the blood sugar.
Good job. Do you know how?
I think it tells it to be stored, right?
And it moves the glucose from the bloodstream into like the body.
Now, let me explain it again. Okay. Think about it, a blood vessel, right? Blood is flowing and glucose is mixed in there. Too much sugar, right? High blood glucose, high glucose in the blood. Just suppose in the vessel, blood is flowing and it's too much glucose in there, correct? That is diabetes, correct? Now, usually when you eat, right? So you have glucose, but you need as a source of energy, right? That's the gas you need, right? Now you need insulin, which is produced by pancreas, right? Pancreas. Insulin help opening up the channels, the gates. Think about it, that you wanted to enter somebody's house. What do you have to cross to enter somebody's house? Door, unless you're gonna jump over the wall, right? So you need the door to open. And think about it, insulin is the key to open the door. For blood sugar to move in the cells and get stored as a source of energy. Now, when there's not enough insulin present or the cells are not sensitive to insulin, now the channels, the doors doesn't open, which allows entry of glucose from the blood into the cells. Because if that happens, right, then there is less glucose in the blood left, right? Because it moved in to the cells. But because it didn't open, they keep flowing in the blood. And that's exactly the problem is high blood glucose is diabetes. Is everybody clear about the problem? Yes. Now, let's talk about the solution. Okay, I do have some videos, but I'm not going to play that. I would recommend that you guys might want to play it when you get a chance later today or tomorrow. That'll help you to understand some concept, but I want to interact and kind of explain here rather than just showing the video. But they are very informative. Okay, first of all, when we talk about diabetes, before we move on, let's talk about type of diabetes. Type 1 and type 2, right? We're on the same page? Yes? Anything else? Good. Okay. Type 1, type 2. Type 1 usually in younger age. Type 2 is usually later in life. So in type 1, there's no insulin production because the insulin producing beta cells in the pancreas, destruction of those, not producing. So they're not producing insulin. What is the solution? Give them insulin. Correct? This is usually, as I said, in childhood, most commonly. Now moving to type 2. Type 2 is more about insulin resistant when the body cell do not respond to whatever the insulin is there or insulin production is low. This is more because of what we do and what we are in. Lifestyle, sedentary lifestyle, bad eating habits, obesity, physical inactivity, and to some extent, the genetic factors are contributors as well. So the first thing in type 2 is lifestyle modification, diet, exercise, quit smoking, no alcohol. Those are the things should be started. And for 6 months, you try, it doesn't work well, introduce an oral antidiabetic unless the patient has a very high blood glucose and can put at risk of other conditions. Well, then you may need to start more aggressive treatment at an earlier point. Okay. How do we know patient has diabetes? Well, one way is to test. One way is to assess based on their signs and symptoms, right? What is the test? Which test is the gold standard? What is the most consistent, reliable test?
Hemoglobin A1C.
Good job. Hemoglobin A1C. Because those sugar molecules, they attach with the hemoglobin, which has a lifespan of around 3 months or so. That's why they give it more consistent readings over that duration. That's why we do that. Okay. Now, when you identify, or when you're trying to identify that maybe this person has diabetes or signs and symptoms are there, you measure the fasting blood glucose, and if it's higher than 126, indicating diabetes. Then there's OGTT, the oral glucose tolerance test, which is done like measuring blood sugar before and after consuming glucose, drink or food. And then if it's over 200 after 2 hours, that conforms. The third one, or which is actually the more reliable, is the hemoglobin A1C. And if it's 6.5 and above, above 6, equal or higher than 6.5%, that's when you can determine the patient has diabetes. 5.7 to 6.4, that is pre-diabetes. 6.5 and above, that's what the diagnosis criteria is. Okay, everybody clear about the numbers? Now let's look up into signs and symptoms. And they are important, guys, okay? First of all, common 3 polys: polyuria, polydipsia, polyphagia. Now, polyuria, poly means more, urea means urine, more urine. They urinate a lot. Polydipsia, more thirsty. Polyphagia, more hungry. Okay. Glycosuria, glucose in the urea means in the urine. They're spilling glucose in the urine. Unexplained weight loss. They're eating fine, they're doing things, nothing else is going on, they're still losing weight. And in certain cases, blurry vision. It doesn't happen in the early stages, but can in some patients. We know why this happens, so we know the signs and symptoms. This is just a kind of repetition, guys, for what we talked about. Increased thirst, frequent urination, increased hunger, unexplained weight loss, fatigue or blurry vision, and also these patients, their wounds heal slower. Okay, and if we don't treat this effectively, patient will be at a high risk of high-risk drugs, and not drugs, I'm sorry, high-risk conditions, such as cardiovascular disease, neuropathy, nephropathy, which is the kidney damage, retinopathy, eyes, foot problems. That's why diabetics, they have to go every year for foot evaluation, right? Okay, foot exams. Now, once again, the best, consistent, reliable test to do is hemoglobin A1C. And we know the number 6.5 or above, right? What to do first? Lifestyle changes, diet, exercise, healthy weight management. Well, if it doesn't work or somebody high risk needs more aggressive treatment, well, we have oral, we have injectables. correct? And while we do so, we monitor the blood glucose. So let's start talking about these medications. So the types of medication, there are many, okay? There are many. We talked about oral and injectable. In oral itself, there are several. For example, the drug of choice, number one, to start with, that is metformin. Metformin. Then there's sulfonylureas. Then there are maglidinides, thiazolidinediones, TZDs. Then there's DPP4 inhibitors, here's dipeptidyl peptidase 4 inhibitors. Then there's a GLP receptor agonist, okay? Then SGLT2 inhibitors, alpha glucosidase inhibitors, and then come to insulin. Okay? And insulin itself has different types. So now, as we move on, for example, we're going to start with insulin. We need to know the types of insulin, what their names are. Okay, we should be able to identify that this name belongs to that type of insulin, and then how long it takes to start acting, at what time it peaks, means it has the highest effect, so that we can monitor patient for the risk of hypoglycemia at that time. And number three is that how long does it last? So I want you to, even though I'll provide you a table, I want you to make your own table. Okay, write down the types of insulin, how you're going to identify them. Okay, and then what their names are, what is their onset, peak, and duration. Develop one sheet that will help you to answer many questions. Draw that once every day for 4 or 5 days. You won't forget it. Now you might find it easier that our professor just shared. It's the same thing. Why to waste time? Well, this is what exactly you need to do. That your mind is playing game with you. We are not here to do the things which are easy. We are here to do the things which are productive, which are the right way of doing it. Learning is not about just reading or just watching or just writing. It's a combination app. We need to utilize the tools wherever they'll be more effective. So please understand this thing. Do not make a mistake of creating these little tools for yourself. All right. Let's talk about insulin. Now, insulin is a hormone produced by pancreas, right? To do what? To manage the blood glucose. So in type 1, there's none. Type 2, either it's less or the cells are not sensitive. Right? Those are the things going on. So what does it do? Well, it just substitutes whatever they're deficient in, you're giving it to them so that they can move the glucose from the blood into the cells, reducing the blood glucose level. Right? This is how it works, as I mentioned earlier. Think about it. This is the glucose channel, the door. This door has to open, and think about insulin as the key. Insulin has to go in, turn the key to open this channel, the door, so that glucose can enter the cell. Think about it. Here, this is the blood vessel, and blood is flowing, mixed glucose, it's high, it needs to go in. But there's not enough insulin to open this gate for the entry, and that's causing high blood glucose. But if it is, it will open up and the glucose from the blood will enter the cells, reduce the blood glucose. Okay. Now let's talk about types of insulin. Okay. First, rapid acting insulin. So, I'll show you table as well, and you can kind of create something similar and add this information on your own with your hands. They'll help you to memorize. If you just read, you may forget. So just on a large piece of paper, draw a table. First, find out how many rows on each side, down, and from left to right you need. So we're gonna need the names. So there's like rapid acting, regular short acting, intermediate, long acting, ultra long acting. Okay. And then we'll need like, some of the names, examples, then onset, peak, and duration for each one of them. So let me give you an example how we're going to put up. First, we're going to write down, like say in the first block, in the box, write rapid acting insulin. Now, rapid acting insulin. The name tells you they're rapid acting. They act rapidly. They act quickly. They should be used with a meal, right? Because they're going to start acting quickly. If there is a gap between the meal and the insulin, the patient may experience hypoglycemia. So this is the mealtime one. Make sense? Yeah. Rapid acting. So think next. I want to just connect here these relevant things first. Rapid acting, we know will act quickly, but do we know how quickly? Maybe like 5 to 15 minutes. Some say 10 to 30. We usually around this 5 to 15, 20 minutes, the time frame. That's how long it takes. That's number one. Number two, when does it peak? How long it takes to produce its maximum effect between 30 minutes to about 2 to 3 hours. Okay. Duration, how long does it last? About 3 to 5 hours. So the time frame, we know how long it takes to act, when it peaks, and when its effect ends, how long it lasts. We know it's rapid acting, but well, if they did not write down rapid acting or regular acting, they're just giving me the names. How do I identify which one is rapid acting, which is regular acting? Well, this is another thing to add in that box, how to identify. Okay. Write down, they end with log, L-O-G, such as Humalog, Novolog. Write down these examples, Humalog, Novolog. So this will tell you that these are rapid acting. Should be given with meals, right? Now there's another way they can put it. Just in the same box where you're writing their names, write down a little tiny thing, says AGL. What that means is A means as part. An example is Novolog, right? Glucine, which is your G, and L is Lispro. So these are different type of insulins. So you will know as the class and as their name, along with their onset, peak, and duration of action. So we're going to repeat the same step for all other. For regular or short acting, this takes about 30 minutes to an hour to start working. Peaks in about 2 to 5 hours and last a little longer than that, 5 to 8 hours. Okay, now how do we identify this is regular? Remember, the top one, it was Novolog, Humalog, right? Humalog, Novolog. Well, this one will be Humulin, Novolin, but at the end it has an R, represents regular. Humulin R, Novolin R, anything At the end it has R, that is your regular insulin. Okay, this is also called short acting. It just has two names for the same one. And this is the drug can be given via IV, regular insulin as an IV. Moving next, intermediate acting. Now, the regular one, Humulin R, Novolin R, this drug is going to be Humulin N, Novolin N, N at the end. Those are intermediate. Well, we know that there's another name. They are called NPH, NPH insulin. And an important thing to remember about these are the type of insulin. They are cloudy. They are never clear. This is the only type of insulin. They are cloudy. If they are clear, they are bad. And any other insulin, if they are cloudy, they are bad as well. So these are cloudy ones. And they're always, if you're mixing two insulin, they are pulled second. Always clear before cloudy. Clear insulin is always pulled first in the syringe. Cloudy NPH is always pulled second. Okay, and then similar way, you're going to write down the onset, the peak, and duration. Next are the long-acting insulin. As the name say, long-acting. They act for a long time, so they are usually once a day. If somebody asks you how long they last, 24 hours, 18 to 24 hours. Example, Lentis. I'm sure everybody heard about Lentis. Lentis is a common, very common type of insulin used. Another drugs, if you want to, or the classes you want to remember here, DGD, okay, DGD, Degludec, example is Tresiba, then your Glargine, which is your Lentis, and then another D, Detemir, that is your Levemir injection. Only two you need to kind of remember these things, and those are the rapid acting and long acting. So you can use AGL, DGD, everything else falls in the same category. You don't have to worry about that. And then they're ultra long. Ultra long, the difference here is they last longer, even more than 24 hours, up to 36 hours, such as Toujeo. The difference between them is it has more units per ml. Okay, you may see like U300, U500 instead of looking at U100 in your Lentis. So U100 tells 100 units per ml, but these will have more. Okay, and these long acting, ultra long acting, they don't cause those high peaks as caused by others, so they don't put your patient at risk, high risk of hypoglycemia as compared to the other ones. Any question? Excuse me. So as I said earlier, please make sure that every one of you do it your own. Make a table and then write down them, and then write little tiny tips, those tools, the hints for you to remember that. Okay, I'm not gonna play in that next video either, but you should have access to that and you can watch it. This is what I'm talking about. Like, you know, this is not complete, but it's just an example how to create a table. Write down rapid acting, the types like AGL, aspart, glycin, lispro. How would you identify their names like Humalog, Novolog, onset, peak, and duration? So similarly, all classes I want you to write down because you'll be asked questions on this. Okay, all aspects, not just onset peak duration or only this or that, all of them. You should be able to identify what they are, which one rapid acting. If they give you a sparglosis, and you should be able to identify the rapid acting. And if yes, well then what is the onset, what is the peak, what is the duration for each class. Okay, now you may see patients with an order of insulin pump, which they will be using at home, right? Because it comes in pre-filled pans, insulin comes in vials where they'll be pulling and pump as well, which is not I'm talking about the aerosol inhaler pump, which is not effective. You're probably not going to see that much, but the pump is the infusion pump I'm talking about. Continuously release the insulin. Now, important point here. Suppose a patient is going home with insulin pump, which they'll be using at home. It's important to demonstrate how to use it correctly and ask them to give you a return demonstration, excuse me, to make sure patient can use it correctly. That is important. Number two, we are talking here about, giving insulin medication to bring patients' blood glucose down. Always think out of the box. Not necessarily the patients who are diabetic may have high blood glucose or extremely high blood glucose because their diabetes is getting worse. There are other reasons. For example, somebody in hospital, a severe infection, and in hospital itself, being in hospital is a stress. Okay, so those stressful situations, as well as severe infections, or patient with severe infections given certain drugs such as steroids to suppress infection, or they have severe respiratory condition to help them out in the breathing better, they're given steroids. All situation and all circumstances, they're given steroids, their blood glucose will go high. So consider these factors. If they're taking steroids, the blood glucose will go high. Then what can you do? Well, while they're taking the steroid, increase the insulin dose. Correct? That's what we can do. Now, as I said earlier, when there are two insulins pulled in the same syringe, and if one is NPH, the cloudy one, the other is clear, suppose it's regular. Well, what you do, because I told you we're going to pull the clear first. So now you got two vials, okay? You got two vials. One is clear, one is cloudy. And I told you clear we're going to pull first. But say you're going to pull 10 units of clear, 5 units of cloudy. What you're going to do is the syringe you're going to use to pull, just syringe itself, you're going to pull the air to 15. Okay, just pulling the air. Now you're gonna inject 5 units of air in the number two pull, NPH, cloudy one. Then you're gonna inject, push the air, the 10 units into number one, which you're gonna pull first. Is that clear? Anybody confused? Not clear about it? Everybody clear? So the air goes first in number two, which you will be pulling number two, okay? So clear before cloudy. And if a regular insulin is cloudy, what a super nurse would do.
hold the dose and call the provider.
That's bad. Toss it. Nobody can change it. So bad, right? Your regular insulin should be clear. If it's cloudy, boom, trash, gone. On the other hand, if an NPH is not cloudy, well, that's bad. Same rule applies. Okay. Then you may come across, pre-mixed ones and all that. So this is, again, the same information which we talked a couple of times, but let's repeat again. First, rapid acting. Now, when you go through all these, you should have your table ready, put it right in front of you. When you're reading rapid acting, ask yourself, do I remember which are the rapid acting? If not, look at the table. Then you read this information. Try to recall the information first before looking at it. Okay, so you should know their names, like, logs, and with log, what is their AGL thing I told you, Aspart, Gosen, Lispro, and what their onset, peak, and duration. These are very important. I want you to know these factors for each type of insulin, whether they're rapid or regular, all of them. Okay. This is a Afrezza, not commonly used. I'm not sure if you ever seen this, but it's not effective. But this is a inhaler, Afrezza. It acts quickly, but it's not very effective. And it's expensive too, so doesn't justify. Now, these are short acting or regular insulin. They have R at the end, Humulin R, Novolin R. They're always clear, and they are the ones which can be given as an IV. Okay? If somebody asks you, which one can you give? An IV. Short acting or regular acting, same name. These are the only one can be given. Somebody asks you, which can you give? Infusion pump. Same. Now, going back to what we were talking about, the infusion pump. So somebody going home with infusion pump, you're educating the patient how to use it correctly. Then how can you confirm the patient can?
Have them demonstrate it back to you.
Correct. Then same thing I want you to know as in the previous, know the names, their onset, peak, and duration. Then their intermediate acting, these are NPH, the cloudy ones. So if they're clear, toss it. Now somebody asks you, once again, how long does it take to work? Oh, 1 to 2 hours. When do they peak? You need to know that time. Okay, some you may see 4 to 8 hours, some may say 4 to 12 hours, somewhere around there. How long does it last? Somewhere around 10 to 18 hours. Then what else? Okay, with intermediate, another thing to remember. So their peak is a little later. Okay, just say like somewhere in the middle, like 8-10 hours, somewhere there, that it causes peak. The peak means is the maximum effect of the drug. The drug is insulin, so maximum effect of insulin. Now, what is the insulin's effect? Move the glucose from the blood into the cells, right? So insulin does what? Bring the blood glucose down. Now, when you bring the blood glucose down, that power capacity is highest at that point. What the patient is at risk for?
Hypoglycemia.
Hypoglycemia. So these patients, they should be given some sort of snacks around 8-10 hours so that they do not experience hypoglycemia. hypoglycemia. There is a huge gap, after given and the peak. So don't miss that part. It's important. They may experience hypoglycemia. And then our long-acting, as the name says, they act for longer. If they act for longer, it means we don't need to use it too many times. How many times? We need once. So they're good for a whole day. 18 to 24 hours usually they last for. So once a day. And these drugs are, or this type of insulin is also called basal insulins, baseline. They create a baseline. They don't cause peaks. Okay, so very low risk of those hypoglycemia due to peak. Any questions so far, guys? Any or many questions? No, nothing. Okay. This is another way to put up. You don't need that. It's just comparing that the rapid acting, it starts working quickly, goes to peak, and then start dropping down, so it doesn't last longer. Regular takes a little longer to start working, and then also last a little longer. And your NPH is kind of starts working late, but it lasts longer as well. And then this, the fourth one, this is your basal insulin, your length, which lasts longer, so once a day, and doesn't cause peak. And here's some mixed ones, pre-mixed ones, such as your Himalayan, Novoland, 70-30, 50-50. That tells you how much, what percentage of NPH and regular insulin it has. Okay. Condition, high risk, called diabetic ketoacidosis. Now let's break it down. And it's a serious, potentially life-threatening complication of diabetes when the high blood glucose levels and the buildup of ketones in the blood and urine. Why does it happen? When the body cannot use glucose for energy due to insufficient insulin and begins breaking down fat, leading to the production of ketones. Okay, let's break down. Diabetic ketoacidosis. Now, first word is diabetic. So who are the patients? To whom does it happen? Diabetic patients. Why? What happens? Diabetic patients, what happens? Ketoacidosis. Keto means ketones. Okay, keto means ketones. Where do they come from? Because there's no insulin which can shift glucose from blood to the cells, and while cells, they need to survive. They need food, energy, and glucose is their energy, but insulin is not available to transfer that glucose from the blood into the cells. They figure out other way where they don't need insulin's help for food. And what they find out? Fat, right? It starts breaking down fat, and that converts into ketones. Now those ketones are acidic. Ketones in the blood, they are acidic, and that builds up and causes acidosis, too much acid. So in diabetic patients, because of ketones, blood becomes too much acidic, called diabetic ketoacidosis. Everybody understand that? Next question is, what type of patients are at high risk? Well, who are not compliant and diabetic medications, or they're not injecting insulin mostly your homeless people or with have psych issues, they are not compliant. Those are the ones who experience that. Okay, that's a common problem. And yes, Kayla, that is a really good point. These patients, if you walk into their room, you can smell that the kind of the fruit, strong fruity smell. You know, it's like a fruity gum flavor, very strong from their breath. If you go close, you can smell that because of that ketones. So what you do here now, the problem is they don't have enough insulin, right? First thing is you give them hydration, you give them IV fluids. Along with that, you give them what they don't have, that is insulin. Why they got ketoacidosis? Because ketones. Ketones came from where? Fat. Where does the fat came from? Because they did not have insulin, they start breaking down the fat. So now let's give them insulin so that they can stop breaking the fat. They stop breaking the fat, no ketones, right? So fluid, we give them insulin to shift glucose from blood to the cells. Next, with this condition, it's common to have electrolyte imbalance. So you run the labs, and if there any electrolyte imbalance, usually it's the potassium. Okay, it can go either way. So if that's the case, you may need to supplement potassium. Right? That's what the usual treatment about diabetic ketoacidosis. Educate your patient about healthy diet, healthy lifestyle. Okay, that's very important. Stay fit consistently, not once in a while. Now let's talk about important part of this chapter, the oral anti-diabetic drugs, equally important. Now, type 2 diabetes mellitus. Remember, they're not for type 1 because type 1, they don't have insulin. They just need insulin. It's only for type 2 who does not have enough or sensitivity is less. So you do lifestyle, doesn't work well, you need metformin. First, metformin is under the class of bigonide. Okay, so let's actually start the drugs and you will know the different classes. Metformin class is bigonide, and it's only one in that class. Okay, this is the first line. Important to know is how does it work? Means what is the mechanism of action? Okay, very important for all the drugs we need to know. So when you develop your study guide, don't write to explain. Leave hints, make it short. For mechanism of action, write down MOA. Okay, metformin MOA. That's it. And then don't write down decreasing glucose production while liver may also decrease. No. Put an arrow downwards. Put an arrow downwards means decreasing. What it's going to decrease? Glucose production. You know that it's the liver who produces, right? You know the decreased glucose production. And what is decreased absorption of glucose? Another arrow or one arrow in the middle. One side put like decrease glucose production, on the other side a glucose absorption. That tells you how does it work, and then an arrow upwards, write down insulin sensitivity means it increases the receptor sensitivity towards insulin. That's it. 3 arrows will tell you what is the mechanism of action of metformin. Don't write paragraphs. Okay, now we know how does it work. What are the adverse effects? One of the most important one you need to know is the lactic acidosis. That's life-threatening and important to do in order to prevent or avoid that risk is suppose your patient is going for a scan with the contrast dye, a coloring agent, right? Like iodine. So they're going for that, and the patient is diabetic, they are on metformin. Make sure you educate the patient to stop taking metformin 1 day before that procedure, 1 day before, and keep them off for 2 days after. So in the middle is what? Just say CT scan, right? The contrast drive they'll be given 1 day before, 2 days after. Should not take for those 3 days because that can cause lactic acidosis. Everybody clear about that? Any question? So these are important things. You don't need to memorize everything about every drug. You just need to know what is important about that drug, and that's what exactly you need to know. If you open up the book, you have 10, multiple lines, tons of things for everything, but you don't need to memorize everything. Kimberly, question, ma'am?
Yes, is Bigonide the generic name or is metformin the generic name?
Okay, on the top is the class.
Okay, the class. Okay.
Class is Bigonide, metformin is a drug. Like
Okay.
beta blockers, metoprolol is a drug, beta blockers is a class. So metformin is the drug, Bigonide is the class. Make
Okay.
sense?
Yeah.
All right, and metformin is the only one in this class. Okay.
And then
All right.
metformin has the like anti-cancer property to it.
There might some studies shown that maybe reduces the incidence, but that's not what the indication that's for.
Yeah. Okay.
Okay. Now, contraindication, somebody with an active renal disease or, that could be a problem if the kidneys are not functional. Okay, next class. Now remember, metformin increase the sensitivity, decrease the absorption, that kind of stuff. Does it do anything with insulin? The insulin release? No, right? So anything which does not stimulate the pancreas to make more insulin, remember that does not put your patient at risk of hypoglycemia. So metformin, very low chance, does not cause a hypoglycemia incident unless the patient just decides to stay hungry. Okay, so remember these things. What is important now? Metformin, that part is not important, but now in this class, that is the most important thing. Why? Let's talk about it. Sulfonylureas. Now let's break it down. Sulfonylurea. This drug is a sulfa drug. So anybody allergic to sulfa drug, they should not be taking it. There are 3 drugs in this class. Glimepiride, glipizide, glyburide. Okay? 3 Gs. 3 Gs. Next question, how do they work? What is their mechanism of action? Okay, problem with the insulin, it tells the pancreas to release more insulin. So that's the mechanism of action. Just put an arrow up and then insulin, increase insulin. Yes? Okay, now let's connect the dot here. It is going to tell the pancreas to release more insulin. Why? Because the blood glucose is high. So insulin will bring the blood glucose down. Blood glucose down puts a patient risk of what?
Hypoglycemia.
Hypoglycemia. So this drug touches insulin release, increase risk of insulin puts very high risk of hypoglycemia. So in these patients, you need to monitor the blood glucose more. It's very high risk of hypoglycemia. So that is one of the most important things to monitor. Okay. Any question? And if patient, the diabetic, they just check the blood glucose and it was high, and they're going for exercise where they know that they're gonna burn, and that will also help bringing down the blood glucose. But if they say, why not I just take this glimepiride? That'll help me now because it's high. Well, no, no, and no, because it's going to increase insulin, will dramatically decrease blood glucose, and you're gonna work out, that will drop even more. So no. Also, with this drug, do not drink alcohol. Reason, it can cause a severe reaction called disulfiram reaction. Disulfiram-like reaction. It feels like a doomsday, maybe one of the worst feelings they could have in their life. Okay. Crazy, super nauseated, throwing like anything, flushing, they're sweating, they're dizzy, throbbing headache, like they're not gonna make it today. Right? That's how they will feel. Very severe reaction. So no alcohol with this drug. Okay. Everybody clear what is important about the slide, this class of drug. Everything else, don't worry about it. What is highlighted, what I told you is important. That's what is important. Next class is glynides. They end in glynide, rapaglinide and netiglinide. There are only two. First question, how do they work? Okay, so they are also one of those, but not anywhere close to the previous class. They also stimulate the pancreas to release insulin binding to the beta cells, beta cell receptors. They work quickly, but the duration of action is short. So these are more effective for postprandial, after meal peaks. Peaks because they ate. So they are usually given with meal. So if somebody asks you, what is the best time to give? With meal. That is also important to know. Now, adverse effect, we know this also increase release of insulin. So the high risk is hypoglycemia. But it's not equal to the previous one. This is less. Okay, next, thiazolidinediones. They're also called glitazone because they end with glitazone. Pioglitazone, which is lactose, and then Avendia is rosiglitazone. So first question is, how do they work? What is the mechanism of action? They're key part. They call the peroxisome proliferator activator receptor in the adipose muscle and liver tissue. They enhance the response to insulin and promoting better glucose uptake. Okay. If somebody is taking this medication, very important to know and monitor is their daily intake, output, daily weight. Now, what kind of patients we monitor daily weight?
Heart failure.
Heart failure. So that tells you that this drug can put your patient at risk of heart failure. So it is contraindicated in patient with class 3 and 4 heart failure, as well as the patient should be monitored for any signs of heart failure, such as edema, difficulty breathing, shortness of breath, all those indicators points towards heart failure. So that is extremely important. Okay.
When they stop taking the medication, if they were to get symptoms of heart failure when they discontinue the med, does it resolve?
So if that happens, it depends on the level of severity. So if it's just happening, you are able to identify in the early, most likely you pull the drug back, they might feel better, but not always the case. It may not be reversible in some patients.
Oh, that's terrible. Okay.
Yeah, so that is why monitoring and knowing before you give the drug, you should know what you should know about that drug. If you don't know, this can put patient at more risk. What you're going to monitor? If you're not going to monitor, how would you identify? How you have no idea to identify, or you end up going to hurt the patient, right? So we don't want to do that. All right. But I would say if, and that is the reason we tell the patient to monitor this every day, right? So that they can catch it right away. And initially, majority of them, I would say that is reversible. But if it's delayed, may not be the case. Okay, all right. Everybody clear about this class? Any question? All right, so let's move on, guys. Next is your alpha glucosidase inhibitors. These are now the first line. They're acarbose and miglitol. First question is, how do they work? Okay, they inhibit alpha glucosidase. What is that? It's an enzyme. Well, why it's fighting with the enzyme? Why it's blocking the enzyme? Because this enzyme, which is found in the intestine brush border, which breaks down the complex carbohydrates into simple sugars. Here we go. Sugar is a problem. So when you do so, it slows down the absorption of glucose and help prevent like a sharp peaks after the food. Then what is the right time to give? With food, right? Because it helps preventing postprandial after meal peaks. So very important when to take with this drug is with meal. So you say first bite of the meal. That's when you should be taking. That's an important educational point. Okay, moving next. DPP-4 inhibitors. They're also very commonly used. They're gliptins. There's sitagliptin, sexagliptin, linagliptin, algliptin. There are 4 in there. You may know by brand names like Trajenta, Januvia, and when Januvia, it's mixed with metformin. It's called Janumet. It's a combination. So gliptins, how do they work? Well, they inhibit what that is, DPP-4. It's an enzyme. They inhibit DPP-4, which is responsible for breaking down a hormone called incretin. Okay, breaking down incretin hormone, for example, such as like GLP-1 and GIP. So it enhances the effect of incretin. Once again, they are gliptins, and a common adverse effect with this class of drug is upper respiratory infections. Upper respiratory infections. That is something important to remember. Okay, now SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors, SGLT2. they ends with flows in. Now, guys, how I was telling you about insulin, how to make a table for all these too. Like, write down SGLT2 inhibitors, write down the common names under that drug, write down MAO, how does it work, and point arrows and do things so that you can fit in a small box. Okay, don't try to just kind of put everything in theoretical way. Makes much easier when you put it in tables. It's a clear, just relevant information. You can't point it to much details as long as you know what it means. Okay, so they inhibit the SGLT2 in the kidneys. SGLT2 inhibitors, so they block this SGLT2 protein in the proximal, your renal tubules, which is responsible for reabsorbing glucose back into the bloodstream. So you're not letting that happen, flushing more glucose out. Okay, you're blocking the gentleman who was making the blood glucose to be reabsorbed. So you block it, not able to help out to absorb the glucose back. So what is the result? More glucose going out. More glucose going out means less in the body. Now, very important to remember. When more glucose is going out means in their urine, the glucose level will be high. So don't check their urine level. Urine glucose level, it'll be high. But these patients, because of this reason, the lot of sugar mixed in the urine is going out through the urinary tract, and sugar is the best food for the bad guys, infectious agents. So these patients are at very high risk of urinary tract infections, UTIs. What can you do to minimize? Well, tell them to make their urine more dilute by drinking more water. There is a problem. We need to monitor and we need to provide a solution. And these drugs, and then flozin, canagliflozin, dapagliflozin, empagliflozin, Invokana, Foxiga, Jardians. These are more newer drugs, quite effective, and they also don't cause that hypoglycemia risk and stuff as compared to your glyburide, glimepiride. They're not safe drugs, but they're cheap, still used. Okay. So as I just told you, UTIs, yeast infections, these are very common.